Okay, thanks for returning after the break. I'm Dr. Lee Mills, one of the PTAC co-chairs. As you know, PTAC will issue a report to the Secretary of HHS that will describe our key findings from this public meeting on using data and health information technology to transparently empower consumer and support providers. We now have time for the committee to reflect on our three incredibly rich and informative sessions today. We will hear from more experts tomorrow, but we want to take the time to gather our thoughts before adjourning for the day. So committee members, you know the drill. Flip your name tent up when you have comments. We do have a page of potential topics for deliberation document if you want to reference that. And please raise your hand on Zoom. And who would like to start? Okay, well, I'll jump in there then. That going first means I have original things to say. That dwindles over time. So I was struck throughout the day today, as we talked so richly about patient engagement, that as someone said, work to make the data more liquid, which I just thought was such a rich analogy. But as we do that, the whole patient engagement is necessary but not wholly sufficient in and of itself to get to where we want the healthcare system to go. And engagement to be effective requires, a principal concept of a free market economy is that the consumer has agency and can make choices. And it's unfortunately true that at many, many steps in healthcare ecology, patients' choice, even if they had perfect information, is very limited in what they can choose, whether it's a network, whether it's a procedure, whether it's there are limitations of transportation and social determinant limitations, all sorts of limitations. But I do wonder if in the fullness of time, the increase of liquid data will drive and spur natural explosion of innovation and competition that will break down those barriers and increase agency at the end. So in a sense, it comes into its own over time. Thought the concept of the coming of the idea of a federated identity is really, really key. And Amy spoke so eloquently about breaking down portal-itis. I think that is really a powerful concept. And, I heard her say that it's happening right now all over health systems, and health plans are using federated identity, whether it's Clear, whether it's ID Me for that. And I'm very grateful to hear that and would love to know others' experiences, but at least in the region of the country I'm familiar with, I don't know of a single health system or health plan that's actually doing that or talking about it now. And so innovation diffuses. Amy also spoke very eloquently about the importance of the person-centered health data apps that aggregate from across, and we saw how in David's talk, how the fragmentation is so dramatic, way larger than any one health system or ecology. And so it's really going to require, for true patient empowerment and to improve agency, it's going to require a person-centered app that can go out and gather that information from all sources and consolidate it in a way the patient can use, and that's really powerful. Love Tom Lee's statement that there is no best way for money to change hands in healthcare. That was just really, really great. There's only a list of things that we've tried that don't work. And so that and the idea from later from Tom saying we've just simply got the way to begin is to just do better with the data we have and not let perfect be in the way of the good. I think that's just really wise, and we do have lots of data that isn't used terribly well today, and so it just spurs us on each and all of our own individual venues to try to use what we have better. And then I enjoyed Dr. Kendrick's comments about about having visibility and a view of data completeness is a critical component of data quality. You think you've got what you need, but if you only have 60% of the patient in front of you of their data and it's fragmented all over, you really never will have a view of the patient that's real, and being able to quantify at the point of care what view of the data you're seeing in your EHR system and what is known to it is really, really important. And seems like that ought to be a critical component in this idea we've talked about in other metrics of clinical quality metrics moving towards ECQMs. Knowing that I'm only at 65% for this metric, but that I only have 40% of all of my patients' data contributing to that is an important concept versus I'm at 45% and I've got 90% of the data, meaning I'm actually at 45%. So, okay, that's what I've got. I will go next to Lindsay.
Yeah, thanks, Lee. Maybe just one tangible recommendation I heard, and then maybe a couple cautions. I think the tangible one that just is worth repeating is, I think just the call out to think about how we could unlock APIs for better access. For example, I think given moving the meaningful use requirements onto API stacks as opposed to on the vendors themselves. I think I heard a caution with regards to payment that I think is worth restating. So one of the concerns around the increased use of data was around a hesitation of data sharing or restrictions on the use of information that's provided for value-based care, then being turned and used against someone for the purposes of payment. So when an entity would provide the clinical information or data for the purpose of clinical quality improvement, for example, then that information could be used against them. And I think as we think about the increased information we'll get from wearables or other health data from things worn by a patient 24/7, I think there's real potential that that data could be used for adverse determinations or other things as well. And so I think a word of caution around as we think about all the uses of data when it comes to payment. And I think exciting to see what we will learn from the use of wearables and AI to actually show improvement in outcomes. I think there's a lot of data out there, but it will be important, I think, as Ricky called out, for companies who are in this space to show that they're not just aggregating and creating bundles of data, but that it's improving outcomes. And so I think it'll be interesting to see the lessons that are learned from entities that are taking risk and incorporating the use of wearables or other AI tools to see how we might value the improvement it provides in for translating to other fee-for-service or other payment methodologies.
And Krishna.
Yeah, from my sense, I have three things sort of stood out for me. One is on just, I think I was pleasantly surprised hearing Kirsten from Be Well and Epic, just the amount of patient-mediated interoperability and data sharing, like they're initiating queries and initiating requests. Great to see the progress made there. There's obviously billions of data points. That was interesting for me. And then how do we continue to sort of find ways to encourage more of that, whether it's through benefit design, whether it's through incentives, I think is one to sort of make them be in control of the data, but also initiate sort of more liquidity and movement was interesting for me. So I thought it was interesting. The second one was on just consistent thought on just like what people are doing to make the data more usable. I just feel like we were so focused in the world of interoperability around just liberating the data. And I think I like the pivot we're making in this sort of a second decade of interoperability on what do we do with it and how do we make the data more usable. And we saw that sort of interspersed in many speakers, whether it's Amy from Included, particularly around sort of integration is the innovation type catchphrase she had on how they're combining data, presenting it in a way that's useful for them to sort of engage and take action. I thought was helpful there. And similarly in the ordering approach, how do they get the data and how do they actually make it usable and presentable in a way that was understandable and actionable, whether it's the cardiovascular age type concept as opposed to a sort of a nerdy, sort of a pulse velocity metric, or in the example that Vishal had on just a sort of gamification, modification, to sort of do something in the data to make action happen. So I thought it was interesting. the things we can learn, particularly as we have all these pledges that are doing the CMS health tech interoperability work. We're going to see more data, more apps coming in. The third point was really around value-based care. I think for me, just more opportunities for us to, I think Abhinav's point on speeding up incentives, incentivizing more specific things. 'Cause sometimes between like shared savings and capitations, we get sort of lots of things get like sort of stuck under the wash. And so being able to sort of like change certain behaviors on data as well as more frequent incentives, I think that's just something for us to keep thinking about as we continue to give feedback on payment models as well. So anyways, those are three themes that stood out for me.
Thank you, Krishna. I'm going to go to Jay and then Larry.
Well, I was encouraged to hear during the wearable session that these companies are taking into consideration that when the business case is made in terms of improved clinical outcomes for wearables and digital tools, that needs to be made available to all populations. That it just can't be self-pay in commercial populations. They've got to be available to Medicare, Medicare Advantage, Medicaid plans as well, and Medicaid patients. Otherwise, we're just going to have a whole new bucket of healthcare disparities in terms of a digital divide. And the second thing that kind of struck me as being absent in today's conversation was the lack of attention to the interaction between primary care physicians and specialists in decision-making for a patient. It never came up. It's kind of, okay, we've got this great data for the specialist to make a decision with the patient, and we've got data for the primary care to make a decision about the patient. But I heard very little about the interaction between the primary care physician and the specialist making a decision shared about the patient, with the patient being part of that process. And I don't know whether it just didn't come up or was an oversight or whatever, but I was struck by the absence of that, especially in today's world with the fragmentation of primary care, which from my perspective is being driven by GLP-1 inhibitors. When you've got Weight Watchers, when you've got him and hers, when you've got Noom now into the weight loss and diabetic care business, it's getting even more fragmented, which means you're going to have less interactions between, quote, primary care and specialty care. So I think we've got to pay attention to that as we build out, value-based care models, not to lose that component of care.
Right, great thoughts, Jay. I'm going to go next to Chinny. And after Chinny is Larry.
I'll echo a lot of what everyone said, except I have a couple of additions. The first being that I'm optimistic after today, because just seeing that there is a march towards more and more liquid data that is becoming more and more interoperable, accessible. Today was a positive meeting in that sense. Just having been in that chair and looking at data 10 years ago in Excel spreadsheets, we've come a long way. Second, I love the idea of federated identity, and I think that that's one of the things that, imagine the amount of people that look at clipboards and the amount of staff that has to interpret that data and enter it in, right? Just from a pure labor perspective and operations. So the more we can do that, and the frustration, so it was really rewarding to see that is coming. And then understandability. A lot of our speakers struck on that, but I did think that nobody sort of brought it to home base, because there is a big gap between data and how providers and patients understand the data and what those insights mean. And even though they're generating those insights, I still think that there's a big arbitrage in that understandability barrier in knowledge, and I didn't really sense that addressed that well, except for a couple of people. What I did like is that there seems to be a convergence where, historically it was like healthcare existed in this silo and retail products existed somewhere else. there seems to be a convergence where healthcare has this sort of patient consumer facing data coming out of it. And then things like the Ring has, the Aura has patient data that is moving into healthcare. And so that convergence of data, I feel, is sort of a new place in healthcare right now. And it seems to be sort of moving. What I would have liked to have seen more of is ideas around reimbursement and how we reimburse not just the accessibility of that data better, but also how to, there's being a primary care physician. It's like now, it's replacing the EMR. Like EMR just gave us volumes and volumes of documentation. I had to fill out 10 pages of documentation. Now that's replacing it with, now I have all this data to interpret, right? And I'm getting people's sleep record from when they're sleeping 24/7. And what am I going to do with that? And so as a family doc, between seeing my 30 patients a day at 15 minutes and filling out my quality and my AWVs, now I have Ring data that of someone maybe not sleeping on a Thursday night, and what am I supposed to do with it? So I think there's got to be some conversation around how do we reimburse for the incredible volume of data that's going to be heading towards doctors.
Okay. Larry, thanks for being patient with me. Larry, and then we'll
No,
go
no
to...
problem, no problem. I think I'm going to have a little chinny, a little J here because I had some things that I was encouraged with and some things that I remain disappointed and fearsome about. And certainly, I think we've made tremendous progress. That once information gets digitalized, we are coming up with better solutions to integrate it and make it available and compile it. And there's been a lot of progress there. I still think that the problem that troubles me is the digitalization period, the point. The interface that both happens at the patient and at the provider level in getting healthcare information into digital format so then it can go on that superhighway. Where we have an Aura Ring, that's cool. Okay, but there are so many apps out there now, and we heard this over and over again that are producing information. They're not integrated. Some of them shouldn't be integrated. And we're having and it creates challenges for us to try to analyze. And I love the story about the obesity between the reporting it on claims or picking it up from BMI. Again, BMI, a very definite digitalization of healthcare information that you can do something with. And yet on the claim side, it's a morass. There's too much heterogeneity in what's being done. There's heterogeneity in the abilities of the providers to provide it, and we still lack financial incentives for anybody to do it. So I still did not hear enough of what we need to do at the patient and the provider interface to get data digitalized. I was really blown away by the gamification piece. I love that. I think we need to study that more and more about, how to continue to motivate people. And the gaming space is a wealth of information for us on there. Finally, on a positive note, Abe left me positive. I feel like I heard from him and from his team a value for our committee. I agree with what they see. I also was happy to hear that, rapid cycle innovation is something they're focusing on. So it's a mixed bag. It was a mixed bag of positives and negatives, but overall, I thought it was a great day.
Thanks, Larry. Josh, and then Walter.
Great. I agree with everybody. I think this is a really great meeting. I think, my comments stem from a few kind of core principles that I'll highlight. I think the first is that I think we definitely need innovation. We need markets to work within our policy and regulatory frameworks. And I think efforts to explore this are good. That said, kind of my North Star, so to speak, really is thinking about the public good, what we're charged with, and thinking about what benefits people who are taxpayers and beneficiaries in these programs, Medicare, Medicaid, and the like. And I think I'll come back to that as I go through here. I think within that, what I've heard from people today, and I fully agree with, is we need system solutions rather than point solutions. I just say here that there are levels to this, right? We're talking about maybe point data solutions versus platform data solutions. But if you take a big step back, I've heard from around the table and from our SMEs that data itself, even if its full sense, doesn't mean care delivery reform, reimbursement, et cetera. There's a bigger system we're talking about here. So I would hope that we would think about that as we interpret what we're hearing. And then the third kind of principle, which is overarching, is kind of that trade-offs to me are inherent. And so, no doubt more liquid data can drive better. No doubt more data requires more time, more energy, workflows, changes. Not all of those, in my opinion, are always better. And more time managing data means less time elsewhere. In the context of payment models, more, payment or incentives for data has to come at a trade-off somewhere if we want to balance fiscal responsibility with, access, engagement, and high quality care. And so I think, I'm not saying anything I think the committee doesn't recognize, but no one said these things directly, but they kept coming up as I listened to each person. And I'll just be brief, but as I think through, what Mark talked about, individualization, he held up his cell phone and talked about apps. I think that's great, but we're in some ways talking about system solutions, right? You're talking about payment models that can have full populations, not bespoke for every single person. And that's a tough thing to do. Amy talked about the need to kind of solve for use cases and deliverize data for jobs to be done. I agree with that. I also think there's an array of stakeholders that have multiple jobs to do, whether that's that person scheduling at the front desk or the caregiver working with someone with multiple chronic conditions and spans the gamut. So again, trade-offs there. Kristen talked about federal ID methods. Really like that idea. I share Lee's excitement about that. I also recognize that the examples given today also happen within pretty tightly regulated, arguably top-down systems, TSA being one example of that. So again, how do you balance that with individualization? Trevor talked about innovations in Epic. I think that's fantastic. I think any strategy that is blank group or company will do it, will fix it, leads to this question of, is that how we drive competition, innovation, and what's best for the patient or the consumer? I'm not sure. Vishal mentioned the 3 Ps. I like that aspiration very much. He also hinted at something though, which is that, again, whether you go to the chain or you tokenize things, there's this question of all of this stuff we do with data and the payment and the delivery models around it. It should accrue value to the groups that are affecting change, but ultimately it needs to accrue value back to the taxpayer, Americans, and the people in these programs. And so I just want to be very careful about that, right? I don't know that there are probably different visions of what solutions and ideal looks like here across stakeholders, and we should be very mindful of that, my own personal opinion. Ricky mentioned the not wanting to kind of drown people under spreadsheets and mountains of data. I agree. Krishna mentioned this pulse wave velocity bit. That said, we also don't want black box solutions, right? We want transparency and we want to safeguard people in use of data. So another trade-off. And the last thing I'll say, because I'm getting long-winded here, is I really appreciated Tom Lee and David Kendrick talking about getting data in front of patients and physicians. And I have to admit, I'm still cogitating on this point, but I think the idea of getting data there compels us to make sure that those data are real. And so for those practicing clinicians around the table, or those in the past, there are data that are put in front of you. You're not quite sure, is it statistically reliable? Is it mine? Lee mentioned, there's levels to it, only 40% of your patients to get to some higher percentage. That's really easy to say. It's much harder to do. And I think both gentlemen referenced that, but I think there's just these trade-offs here. And I just return to that North Star of, we need innovation and we need data, but there are bigger system solutions that we need. And I would love to see it make sure that we accrue value back to publicly administered programs and the beneficiaries and the caregivers that pay into and benefit from it. And in that, I don't think trade-offs are a bug of this system. I think they're a feature, and I hope we elevate that. Thanks.
Thanks, Josh. Walter, bring us home.
Yeah, I know it's a bit past 5 or over time, so I'll try to keep my remarks short and actually going last at its benefits, because a lot of what I had in mind has already been said, so I won't repeat all that. I guess I should just say I kind of came into this public meeting as a bit of a skeptic, and I'm sorry to say I still am a bit of a skeptic in terms of exactly how we are going to use data and health information to better empower consumers and support providers. Maybe I should just pick up where Josh left off in terms of how we're going to pay for all of this, right? I think without that link from empowering patients with this data to health outcomes, I think that's going to be very, very difficult to figure out. We do have a whole session on payment models and benefit designs tomorrow, and so I'm hoping to find answers there. I'm encouraged by the example that Ricky gave about how there's one Medicare Advantage plan who's willing to pay for the digital tool that his company makes because they find value in it. And I think probably a canary in the coal mine will be seeing Medicare Advantage plans actually start paying for some of these tools to validate that there is indeed a link to good outcomes. I am encouraged by the idea that we can actually turn the enormous amount of data that we have into more actionable more actionable information at the point of care. I think Innovaser made that point very, very well, and as did others during our sessions today. The idea that maybe there are platforms that can sit on top of legacy platforms using AI to really help providers make better clinical decisions at the point of care, I think is really important. And the last thing I'll say is, Krishna started off the PCDT presentation by listing out a lot of different areas that patients can be empowered through better data. And one of the first things he said was patients can be empowered to make informed decisions about their choice of health plans and providers. Now, I think that's probably the most important choice that a patient can make about their personal health care. And I kind of hope that we would have heard a bit more about that, about how solutions are out there to help patients digest the enormous amount of quality and cost data that's available to help them make better informed choice about providers. And so I think that's just something I'm hoping to hear a bit more about tomorrow.
Thank you, Walter. And then one last angling, Chad, that occurred to me that I want to be sure we get in the minutes and reflect on is at least two speakers spoke to, as we engage patients with all this rich data and it becomes more liquid and we start innovating and we drive value, we've got to pay attention, and because we are the PTAC, we talk a lot about how to pay for value-based care, but the last mile of that payment going to the physician has in general stagnated, not changed in nearly 20 years. So we need to be thoughtful, but advise as CMMI innovates that they use their tools of policy, their waiver power, and build model elements that require or make mandatory in some fashion the last mile of payment changes to reflect alternate payment models and value, as opposed to continuing to pay based on volume. So with that, I thank my colleagues. Incredible sessions, wonderful discussion, and thank you for all those of you who listened in. We will be back tomorrow morning at 9 a.m. Eastern Time to start day 2. We'll be joined by 8 incredible experts with varying perspectives. Our day 2 agenda will feature 2 different sessions. The first will be on data-driven approaches for enabling patients with chronic conditions and enhancing secondary prevention. And the final session will be covering payment models and benefit design improvements to enhance patient empowerment. There will also be an opportunity for public comments tomorrow afternoon before the meeting concludes with the committee discussion. We hope you will join us then. Thank you. For now, this meeting is adjourned for the day. Thank you.
Produced by the U.S. Department of Health and Human Services.